I'm going to maybe ask legal counsel to weigh in because we have said that veterinarians have the educational and training to perform physical therapy. So the next question is, under what supervision? Animal physical rehabilitation. So the next question is, what level of supervision is required? Is it implied that no supervision is required on what we just voted for?
Yes, I believe it's inherent in the act that once you're granted the license, that you can do this without supervision. I don't think it's a derivative license. I think it's, like I said, a license that once it's issued, you get to do those things essentially enumerated in 4826.
And I tend to agree with that, so I would suggest, in the interest of moving along, that we make a motion that no supervision is required.
I don't think you need a motion.
Or not.
Okay,
then
I do need to announce the votes because we didn't do that.
Oh, that's right. That's right.
For the sake of the count, it was 10 ayes, 8 nays, so the motion did carry.
So then I'm going to say that the next section on supervision, veterinarians are not required to have supervision, any level of supervision, and practice setting, is that any?
It's already defined.
It's already defined in the Practice Act. Then moving on to RVTs. The educational and training that RVTs receive. I don't think we have, do we have somebody for that? Okay, I was saying RVT school, but
I can't speak towards going to an AVMA-approved program. I went and did the alternate route way back in the day, and I have my bachelor's of science in biology with a concentration in animal physiology. So I went through the alternate pathway route. But working with the Academy of Physical Rehabilitation Technicians proposed, we've been looking at a lot of different educational pathways, and that's far above and beyond what we're trying to discuss here. But there's a lot of opportunities for veterinary technicians to gain additional training and hands-on access to just even entry-level physical rehabilitation. The new McKernan veterinary nursing book has, I believe, chapter 22. It's an entire chapter written by veterinarians for technicians on rehabilitation therapies. At this year at Western Veterinary Conference Veterinary Technician Symposium, which was aimed towards general veterinary technicians, there was an entire day on just entry physical rehabilitation to get people interested and to learn the fundamentals. Every single conference, we've already said this multiple times, that there's veterinary technicians who are considered experts giving lectures on rehabilitation. So there's ample opportunities for veterinary technicians to gain additional training. I don't have the specifics for all the different programs in the country, but some of it's included in our links that we have, but it's in there. Inherent with surgical nursing, post-operative care, there's rehabilitation therapies. I mean, you could look at every single specialty. So you start picking pieces apart, it's there. I don't know if you have any other questions, or Sandy could maybe comment.
Speaking from teaching at Foothill College, that we teach vet techs to become vet techs, that it is now an AVMA skill, required skill to know passive range of motion and how to deal with the recumbent patient. And then recommended skills are knowing the underwater treadmill and some of those other modalities. So it is being taught in the schools, and I checked into some of them, and they are doing it either by case study or actually hands-on or showing videos. I didn't find out about all the schools in California, but even in other states, they are teaching it in the vet tech accredited programs.
Dr. Troy.
I talked with Carrington College, which is one of the private schools that teaches registered veterinary technicians, among other professions, and they are just in the middle of revamping some of their curriculum because of the change of the national testing. And the instructor that I spoke with described a curriculum very similar to what Dr. Holland described, in that she includes rehabilitative type therapies when she talks about nursing care, when she talks about post-op, when she talks about neuro patients, when she talks about Down patients, geriatrics, those kinds of things. So she integrates it much the way it is done in the veterinary world, in the universities for veterinary training.
Lee.
So I have a question, and I repeat, high-volume consumer veterinary services, and have done and have been involved in a lot of orthopedic stuff because I also foster for shelters, and if anybody gets a TPLO, guess where it goes to recover. And in all those years, not one veterinarian or vet tech, and I know a lot of them, and I'm friends with a lot of them, have ever said to me, yes, I know how to do animal rehab. They have all said to me, all I know is range of motion. I don't know anything else. So is it that Santa Barbara is a blip on the landscape that has missed this? Or what's going on that in practice, at least in Santa Barbara, what you're describing isn't translating into what people are self-professing about what they know and don't know?
I forgot to mention that I had a request for all task force members to speak into the microphone because not everyone can hear you. Dr. Walden.
I don't know what's happening in Santa Barbara, but it's really a beautiful spot. One thing that I was thinking about, because this plagues me actually on a daily basis, what you just said. For the past 10 years I've been practicing rehab. I have gone once a week or every 2 weeks to general and specialty practices all through the Los Angeles area, teaching veterinarians and veterinary assistants and vet techs how to do a lot of basic range of motion and standing exercises, and they want to know and they want to learn. But I think that, as everyone's saying, the curriculums are evolving and changing, and 15 years ago, or whenever I went to veterinary school, it's non-disclosed, I didn't have that training then either. So I think that it just needs to be, the community needs to embrace it more, and now I hear and see general practices, specialty hospitals sending stuff out all the time, the handouts for rehab post-op or general care, and it makes me feel happier that it is sinking in. But I think it's your area, and I think someone has to get out there and educate, or all the people have to be interested on their own.
You come up?
I will. Can I stay with you?
I like.
I know, you look cute. Thanks again.
So one thing that I think is helpful for task force members to consider at this point is what an RVT can do and what they cannot do at this point. Veterinarians can diagnose and treat. That's what they can do in veterinary medicines. RVTs cannot diagnose, and there are a list of tasks that they can perform that's in our Practice Act, and in this Practice Act is levels of supervision. So I'm going to have Anne Marie just kind of let task force members know what they can currently do.
So under Section 2036 of the California Code of Regulations, it defines specific tasks for RVTs. It defines some tasks that they're not allowed to do. We'll skip those, but, well, I'll mention a few: surgery, diagnosis, prognosis of animal diseases. And then it says that an RVT may perform the following procedures only under the direct supervision of a licensed veterinarian. 1 is induce anesthesia. 2 is apply casts and splints. 3 is perform dental extractions. 4 is suture cutaneous and subcutaneous tissues, gingiva, and oral mucous membranes. Create a relief hole in the skin to facilitate placement of an intravascular catheter. An RVT may perform the following procedures under indirect supervision of a licensed veterinarian. 1 is administer controlled substances. And then it says D, subject to the provisions of subsections A, B, and C, A being the task they cannot perform, B being the task they can perform under direct supervision, and C being the task they can perform under indirect supervision, an RVT may perform animal healthcare tasks under the direct or indirect supervision of a licensed veterinarian. The degree of supervision by a licensed veterinarian over an RVT shall be consistent with the standards of good veterinary medical practices.
So when we're considering, do they have sufficient education and training, keep in mind, task members, what we expect them to do. They are certainly not doing what we expect veterinarians to do. Dr. Klingberg.
Back in 2008, I had the chance to speak to the American Association of Veterinary State Boards, and the topic I was given was forward thinking for RVTs. And I challenged them. I said, you're teaching RVTs wrong. We need to teach them to do things that we would like to have done in the practice, but that the veterinarian may not have time to go out there and gain as much expertise as she or he wants. And I identified ultrasonography as an area, physical therapy, because it wasn't APR back then, and then transfusion medicine, cytology, hematology. It wasn't a very popular conversation because I told the educators there that they were not educating the students properly. But I feel a little vindicated with today's topic, and I would certainly like to consider adding animal physical rehab to the job task list of RVTs as we move forward.
Karen?
I have a suggestion for kind of a two-pronged suggestion here. With RVTs that have CCRA or CCRP, that I think it seems reasonable to say that they should work under the direction and on the same premises, but not on the same, but not be in the line of sight of a qualified physical therapist or a veterinarian, qualified like a veterinarian to render animal rehab services, number one. And number two, limit the scope of type of rehab, so they may not conduct evaluations, write goals, establish a treatment plan, perform discharges, or employ joint mobilization techniques. And then non-certified RVTs would need to be under direct supervision, or immediate supervision, I'm sorry.
Are you referring to veterinary assistants when you said non-certified?
RVTs?
Non-RVTs.
Oh, okay, okay.
Sorry, not, yes.
Okay.
I said non-certified RVTs, so that means the veterinary assistant.
When you say non-certified RVT, you mean those that have not gone through the CCRT
Sorry.
program?
No, non-certified, the ones that have not gone through a CCRA or a CCRP program, those RVTs should be under direct supervision.
So Karen, I'm going to try and clarify what I think you said, because we've got issues of supervision and then certification. And of course, RVTs get a certification, not really a registration. So it's super confusing. I think what I heard you say was that those that have gone through these two programs, the CCRP, and what's the other program?
CCRT?
Thank you, CCRT.
CCRA.
Okay. RVTs that have gone through that may work under indirect supervision, but the supervisor may be a physical therapist or a DVM.
Qualified physical therapist.
Okay. Which you then also mean has gone through that certification program.
The CCRT or CCRP, correct.
And then you said that those who have not gone through those two CCR blank programs, these are RVTs now, are under immediate supervision, which is line of sight.
Correct.
Okay.
I also did have unlicensed assistants as well under the immediate supervision of. So non-certified not gone through the program, RVTs, and unlicensed assistants to be under immediate supervision.
And again, unlicensed assistants is our veterinary?
The veterinary assistants.
Yeah. Shala wants us to use the same term, and I agree, veterinary assistants.
Sorry.
Kristen?
Karen, could you clarify discharges, what you mean by that as a task only for the physical therapist? Because much of what a registered veterinary technician does is discharging from a surgery or, for the veterinarians. So if you could expand upon that.
Right, so it would be, so if a qualified physical therapist, not just a physical therapist, but also a veterinarian, they could give the task off to them, but they need to be under direct supervision for it and get all the information from the supervising practitioner.
And I hear what you're saying. I don't think that we have identified individual task that's animal rehabilitation other than those activities that are done to reduce pain and restore the function. So that's what we're calling rehabilitation. And I know that you're asking for a specific task.
No, I was not. I was just clarifying what you meant by discharges. And I do have a strong concern with the immediate term for registered veterinary technicians, because what that means is the veterinarian needs to stand there in the room while I run the underwater treadmill, which would therefore increase the cost to the consumer. They cannot stand in the room right there watching with their eyeballs. I mean, that's what that means. Direct is they're on the premises. So I just wanted to open that up. That's a concern.
Yeah. Anne-Marie?
Just for clarification, again, we're making policy statements, but for clarification for the public, there is not an immediate supervision level right now in the Practice Act. There's only direct and indirect. So if you were going to recommend something like immediate, it would have to be defined, and it would have to be, that would be in addition to what's currently in the Practice Act for the supervision of veterinarians or veterinary assistants.
Dr. Van Dyke, then Val.
My comment early on here was about the concept of allowing RVTs to practice animal rehabilitation. I think that it is of concern that the belief is that rehabilitation is a lot of exercises and using things like treadmills and lasers and that sort of thing, when in reality, probably 90% of what makes rehabilitation improve on the results we get with human or animal patients is the diagnostic algorithm that is quite different. It is quite different from how we have been trained as veterinarians to look at muscle, bone, joint. It is a very soft tissue oriented diagnosis that truly alters the treatment plan and allows us to do really specific therapies. So if we suggest that RVTs should practice rehabilitation, what we're doing is giving them something that's 90% eval and 10% therapy, which is why we are suggesting, or I would suggest, and I would applaud Karen's thoughts on how to define how an RVT works within the physical rehabilitation team. The downfall we are concerned about is practices thinking that you have a technician who is trained, they run the rehab program. The vet understands, because they've had education, what rehab's about, but they have their technician go and run the program. Now you have a technician who can't do the diagnostic piece because scope of practice, and therefore has a very limited ability to improve on the patient's function. Somebody else has to be doing the diagnostic piece. So I think when we define how technicians, and we need technicians to do this is the only way this practice can survive fiscally, is to have the technicians doing most of the time-consuming work. But the diagnostic piece has to be done by someone who's trained in those skills beyond the way we learn in traditional veterinary practice.
Val?
So I want to clarify if this is occurring in a veterinary practice, because currently RVTs can only be supervised by veterinarians, and the veterinarian is the ultimate supervisor of everybody. So I just want some clarification. Thank you.
Dr. Troy, and then Dr. Slachter.
I just have two comments that concern me about what was proposed. One is, I think that we would be extremely self-limiting if we use the certifications provided only by CRI and UT. We don't know where they'll be in 5 years. We certainly hope both programs are flourishing. We don't know if there will be other opportunities for people to become educated and trained in a formal setting, to develop a different set of initials after their name. So I do have a lot of heartache with referring to those initials, despite the fact that I've earned some of them, and I've taken some of Dr. Van Dyke's courses and appreciate them. I don't think we should be putting into regulations, though, that funnel any type of training into two specific courses. That's my first concern. My second concern, and I appreciate what Dr. Van Dyke said about so much of the diagnostic process necessary in this, and it's true. I agree with it. But we limit then if we have physical therapists there, because they're not by law allowed to diagnose veterinary patients either. So we still have to have some veterinary participation in this, and how they work together as a team. I think about what was presented at Carrie Ann about the collaborative effort, and while I don't think collaboration should be regulated, I think it should be encouraged. I think that we would lose out on not having RVTs actively participating in assessments along with the rest of the team, because they possess a keen eye to veterinary medicine that the rest of us do not possess because of where we come from and where we're headed. Their direction is a little bit different, and their background's a little bit different.
Dr. Slachter?
I'd like to actually reiterate both of the points that Dr. Troy made, but the first one being that I work with a number of animal physiotherapists from other countries, quite well, and I think again that's it's an area of education that hasn't really, the United States hasn't really gone there at all. So it's sort of both worlds combined, and I find them to be incredibly valuable. I don't know how that would fall into what we're doing here, but I think the second part that you guys, Dr. Van Dyke also brought up, is that I live that every day. I mean, I run a 33-acre rehab facility. I have 2 RVTs, one of which is CCR. I'm not sure which one she got certified, but every day she assesses those horses, working with a team of veterinary assistants. And then I'm either called in to assess or go through and assess them essentially on a once-a-week basis. So we run anywhere from 15 to 25 horses through this rehab program, and it is all, I mean, probably 90% of the cases are soft tissue cases. So again, I think it is feasible to get all of that done, without being with the RVTs. And I will tell you, I call my animal physiotherapist, or one of them is a human physical therapist, in on at least 60% of my cases. So I think all of that is, feasible to be done under the laws as they stand right now.
And I want to reiterate what you just said. You said the RVTs will assess the progress of a course of physical rehabilitation, but they won't diagnose that things need to be, they'll take that to the veterinarian, who actually will make a change in diagnosis or make no changes. But they certainly are helpful. Yeah, but their assessment certainly is helpful for outcome of the case and monitoring. Mm-hmm. Yeah. Karen? And
It's quick.
Zach.
I just wanted to, I totally agree with you, Dr. Troy, about not picking one program or the other. I think this should be teased out by just figuring out what those competency standards look like and go from there, instead of picking a UT or a CRI program.
My note is that when I went to school to become an RVT and sitting before the National State Boards, we have to know about all the animals. So not just about canine, but we also have to know equine and rabbit and cats and wildlife, which is something that we haven't really addressed, but I know that's part of the APR with this. So I think that's a huge factor in assessing and working with these animals, and I think it's very valuable that we know about all these animals that we are dealing with.
I don't want to confuse the issue at all, but wildlife is exempt. It's under fish and game.
But just the point that we could work with.
Yeah.
Sorry. No.
Dr. Walden?
I just think that the RVT's role in veterinary medicine is the right-hand man or woman, and they are our eyes and our ears, and they have a lot of training, they have a lot of education. They're actually proposing a Academy of Physical Rehabilitation for Veterinary Technician group. So Kristen is heading that. So they're super motivated, interested, educated, and I think they already practice under a direct supervision model. And I think that we've all used examples here of how they're practicing successfully like that. So I propose we just keep it consistent.
Kristen?
So, all the academies for veterinary technicians that we're talking about, which it's all proposed, still through NAVTA. So our framework that we're working with is going to be a points-based system. So we are not going to require any specific schooling of certification at this time. There's continuing education hours. Your continuing education has to be provided by an expert, sports medicine specialist or another recognized veterinary technician specialist, because we want to allow the general practice registered veterinary technician the ability to become an expert without having to go through the schooling with their veterinarian. Every veterinary technician has to work with a veterinarian in direct supervision. There's no exceptions for that. I look at this, and it's very similar to a nursing care plan post-anesthesia. The veterinary technicians were assessing the patients. We're making recommendations to the veterinarians based on how the patient's responding with their pain management. This is very similar. It's a framework. We have the basic foundation to make suggestions and treatment plan changes that the veterinarian ultimately decides upon. Without a veterinarian, on a day-to-day basis, I would have a very hard time doing my job. There's various red flags that go off all the time. Even if it's just, as I call it, a drive-by, question or an exam for one of the patients that comes in. And I would like to say that I do not work with, and I never have worked with directly a sports medicine specialist or a rehab certified veterinarian. So I have always worked with general practice veterinarians. They have all been very supportive of what I do. It's a team effort. We work together. I'm assisting with the evaluation that they are doing. The animals are coming in with a diagnosis. It changes as needed. So it is doable, and I feel that the general practice is what we're looking at the majority of here, not the rehab facilities scattered throughout the state. That there's maybe quite more people that we're not thinking of. And so if we limit education, requirements, that we might be limiting access for the consumers ultimately.
Lee?
So I want to return to the concepts that I think Karen was raising, although not necessarily the exact language. It seems to me there is a big difference between someone with the additional training and passion for training that you have and the typical RVT. And again, no disrespect to RVTs. They do amazing work, and it takes a lot of work to do that job. But I'm interested in consumer protection. I'm imagining a general practice in which you have a general practitioner, a good vet, but trying to treat all kinds of things, and an RVT who has had no additional training other than the standard curriculum, thinking that that's sufficient to provide animal rehabilitation therapy, which is a specialty. So how do we address some kind of guidance on that, so that that's not the model that people think is sufficient to provide a standard of care for their animals?
Would it be helpful to think about who's ultimately responsible for the outcome? If a veterinarian has prescribed a course of physical therapy and the concern is harm being done, and physical therapy is done by an RVT, under direct supervision of the veterinarian, and that RVT is not sufficiently trained in physical therapy and harm is done, will the RVT get in trouble or will the DVM get in trouble? And if the answer is the DVM is going to get in trouble, then is the DVM going to make sure that that RVT already knows how to do it, or else they're going to get in trouble?
I would like to think that that would be the motivator, but liability after the fact is not necessarily sufficient protection from bad action. So from my perspective as a consumer advocate, I'm looking for us to provide some kind of guidance or framework that identifies who is competent and under what circumstances. Now talking about RVTs, we've already moved on from veterinarians.
Dr. Choi?
I think, Lee, it's sort of the slippery slope that we visited with the veterinarians, because when I hire a new RVT licensed in the state of California, I legally can hand her a syringe or let her draw it up or him on themselves to anesthetize your dog when it comes in. Now, I can do that legally and walk away. I don't, because in my practice, as do most of us practice, we are responsible for assuring, not thinking, not hoping, but assuring the competency of that person that I give that job task to. So if we look at those job tasks, for instance, and Kristen and I were having this discussion about dentistry, the bane of the existence of the majority of the veterinary profession. However, very important things can happen and very dangerous things can happen. And while all RVTs can legally take out a fourth premolar, most of them should not. In fact, I know a lot of veterinarians that should not. But I am responsible, and in my hospital, I have 6 doctors and 5 RVT. Anyway, I got a lot of people to be responsible for. Not everyone in my hospital, our RVTs, are allowed to provide every therapy that falls under their purview. And so there is a huge responsibility. And while it's not preventive in the rehab world, it's not preventive in the anesthesia circle either. When I have my RVTs that are anesthetizing your dog, they're not certified.
But I feel more confident of the training that an RVT receives about administration of anesthesia than I do about what they're getting around animal rehab, because that's a fundamental component of the RVT curriculum, anesthesia. It has to be, because it's one of their chief jobs.
What it currently reads in the Practice Act is, the supervising veterinarian shall be responsible for determining the competency of the RVT or veterinary assistant to perform allowable healthcare task. So what we're proposing is saying we don't think the DVM is responsible enough to make that determination. We feel that they need to have, I think that's what you're saying, is you have to make sure that that RVT has been thoroughly trained to perform the task.
I think where Karen and I are both going is that because it's not, doesn't have the same status in the RVT curriculum that something like anesthesia should, by the way, because anesthesia is so critical, that it's not something that we feel that is covered by the current Practice Act as sufficiently to provide consumer protection.
So this is not sufficient. Shala?
I just want to say again, consumer protection, I think looking at who's going to get in trouble if something goes wrong is maybe the wrong direction. I think we should be looking at it as to how to prevent something from going wrong. And the best practices to do that, and whether that's education or supervision, I don't feel like I'm qualified to say, but I do feel like prevention is probably the best medicine at this point.
I mean, I hear you. I do read this as a preventative measure. It's saying that you better make sure that the person that you're telling to do this task is qualified to do this task. I'm not sure how that can be interpreted as not a preventative measure, because that recommendation is made so that a mistake is not made.
Can I ask a
question?
Jason, would you mind approaching? Sorry, I'm going to put you on the spot here. The reason I'm asking a question like this is that we're talking about kind of a common structure in all healthcare fields, not just veterinary medicine, where the independent practitioner has discretion and authority in terms of what they delegate. And this is not an uncommon model. This is kind of the model across the board. the consultants over here nodding because we see this every day all the time. In physical therapy, is it the physical therapist's purview to delegate tasks to a physical therapy assistant based on that assistant's training and competency? Or are there very specific things that are outlined that cannot be delegated, which there are in veterinary medicine? It was the diagnosis, surgery, those few things. What's the model look like in physical therapy?
As you stated it right now, all those things are true. A physical therapist is ultimately responsible for all care that's provided to a patient. And there are 2 assistive personnel that they can utilize. An unlicensed.
Yeah, it is.
Doesn't sound like it.
Unlicensed physical therapy aide and a physical therapy assistant. And so it is the physical therapist's responsibility to ensure that both the PT assistant and the PT aide are competent in any modalities that they might administer under the supervision of that physical therapist. And it should be documented.
And I'm sorry, you didn't introduce yourself.
I'm sorry.
So,
My name's Jason Kaiser.
ask
Put
Henry
him on
who
the
you are.
spot. Sorry, Jason.
I'm the executive officer with the Physical Therapy Board.
You're Anne Marie, but in a different board.
I am. Maybe not as graceful, but I am.
Thanks, Jason.
No problem.
Okay. So what we just heard was that physical therapists are responsible for assigning tasks to physical therapy assistants, but we're proposing that veterinarians should not have the ability to assign tasks to RVTs in the specific area of physical therapy, animal rehabilitation. That's what we're proposing.
That's what someone has said. I don't know that anybody's proposed that,
Yeah.
but yes.
A motion wasn't made, but
Right.
that's the direction it's going.
No, that's what somebody has offered. There's no direction there. It's just a discussion point.
Okay.
Yeah.
So we're on the level of RVTs, and the question is, what they currently can do is healthcare task that we've already determined is the practice of veterinary medicine. And do we need any motion to change what currently stands?
Sure.
Since the task force is inclined to make, you can't hear? Okay, it's on, I don't know what the deal is. Since the task force is inclined to make policy statements, and that's why this document is a nomenclature document, the Practice Act does not define the task of animal physical rehabilitation for RVTs. It just defines what RVTs can do under direct supervision and indirect supervision. No statement at all would probably lend itself to RVTs could still do this under indirect supervision, because it's not specifically called out that it must be done under direct supervision as it currently stands. I can read again what the direct supervision language is. It's induce anesthesia, apply casts and splints, perform dental extractions, suture subcutaneous and cutaneous tissue, gingiva, oral mucous membranes, and create a relief hole in the skin to facilitate placement of intravascular catheters. And then it says that an RVT can perform procedures under indirect supervision, and it talks about administer controlled substances. I guess the kind of anomaly here is subject to the provisions of A, B, and C, A being cannot perform, B being direct supervision, and C being indirect of this section, an RVT may perform animal health care tasks under the direct or indirect supervision of a licensed veterinarian. And it says the degree of supervision by a veterinarian over an RVT shall be consistent with standards of good veterinary medical practices. So if the policy is that we think that the the veterinarian can decide what level of supervision is appropriate for that RVT based on their education, training, and competency, nothing more needs to be done. However, the task force could make a policy statement. If there is a specific direction here from the task force that we think this needs to be done under direct supervision, that would need to be stated If there is a specific policy statement that we think this can be done always under indirect supervision, which I doubt that's going to come out of the task force, but that's also something that we would need verbally stated because it really is unclear in the Practice Act what degree of supervision an RVT must be under when doing animal physical rehabilitation. Again, if nothing's done and no policy statement is made out of this task force, the current structure would allow the veterinarian to decide, based on the RVT's competence and training, what level of supervision is appropriate. Does that make sense? Okay.
I think so.
Request for clarification. So it sounds like we can choose to simply affirm the current practice under the Practice Act or offer an alternative as a policy statement. We need to do that.
And to further that, I think the alternative would be to make the motion that they can do it under direct supervision and not allow the veterinarian to choose direct or indirect. That's the other option. Yes.
I want to speak up for the equine component. I know we're a smaller component of all of this, but it would be more than onerous and extremely expensive to try and have direct supervision, even on a 33-acre property all of the time. You know, I mean, it's one property, but to keep a vet on site all of the time would drive the rehab facility that I'm at out of business very quickly. And I think most of them the same way.
Thank you. Have we abandoned or put aside any notion of educational requirements or certification requirements in addition to the issue of supervision, direct and indirect supervision? I thought we kind of didn't complete that that part of the discussion.
We did veer from what I tried to do, but I thought the discussion was moving along, so I didn't object, but it's not off the table.
Okay, thank you.
Go ahead. One of the things that I've discussed with my partners in the business would be to have, and this may not be feasible, but to allow an RVT who has had some sort of continuing education in something work under indirect supervision versus an RVT that has not had some sort of continuing education work under direct supervision.
Chair Nunez, I think that was roughly Karen's proposal, but with some significant input about taking out specific certifications, right?
If I could make one comment, I'd love to find a way to have language that suggests that an RVT doing this under the direction of a veterinarian, whether indirect or direct, is receiving that direction from a veterinarian who has pursued additional training in this field. Just as a suggestion, I really, you know, I'm not saying it's a requirement, but if there's a way, as a task force, as we're sending our comments to the board, I think it's important that the board hear that the veterinarians who are in charge of these cases, if they're going to hand them off to their RVT, should have done the diagnostics that are appropriate to a physical therapy evaluation prior to asking their RVT to carry out whatever techniques they're going to do.
Chair Nunez, can I try to formulate a motion or so? Okay.
Let's have Sheila first, then you can give it back.
Are we skipping over asking or suggesting that the RVT have additional training?
No.
I was, in addition.
In addition, okay.
Go ahead.
I'm going to take a stab at this, and if it comes out kind of mangled, please help me to clarify. So this is rough language. The task force, picks, suggests, or encourages, recommends veterinarians and RVTs engaged in the practice, can take up practice, you want, engaged in animal rehabilitation therapy, to pursue additional training, and that RVTs with additional training be able to practice with indirect supervision, and that RVTs without additional training be required to have direct supervision. Is that a summary of what we were saying?
By throwing in veterinarians, you did what was attempted. with-
Sorry,
from the
okay.
amendment. So,
Okay, well then take out the veterinarian, sorry, I didn't mean, okay. Suggest that RVTs pursue additional training in animal physical rehabilitation, that RVTs with that additional training be able to perform, I'm trying to avoid that word practice, animal physical rehabilitation with indirect supervision, and that RVTs without additional training be required to receive direct supervision. I'm trying to get to where I think we're going. Am I covering it?
Yes, I think we are, but I'm having a hard time, and I totally understand your point that people should be trained before they do things, absolutely. But, we have orthopedic surgeons prescribing passive range of motion exercises after the TPLO, for example. So that surgeon may not have specifically gone to a rehab training CE, and they're prescribing it for their technician. So how is that a different healthcare task from, say, taking now, being able to extract teeth, apply casts and splints? Splinting is very integral to what we do in rehabilitation for various reasons. Everything's a veterinary prescription, but it's getting a little muddy for me, so I'm having a hard time following the words.
I'm having a little trouble articulating.
I think the spirit is somewhere in the room. We're just having a hard time capturing it.
Could we find a way to put wording in that we're trying to dance around this issue of practicing rehabilitation as an RVT, but can we figure out a way to make the language be that the RVT is following the orders of the veterinarian or the certified or the advanced trained therapist, so that it's clear that the RVT is not being asked to develop a plan of care, do an evaluation, and develop.
Is that performing healthcare tasks?
Yeah, it's performing healthcare tasks is the right vernacular, and we don't say practicing, and in the motion it was provide services. So that's more in line with what we say RVTs do, is provide healthcare services or animal healthcare tasks. But
Right.
It doesn't say, I don't think we're using, I think we said engaged in the practice of defining animal physical rehabilitation as a practice, but that the RVT would be providing services, animal physical rehabilitation services, or performing animal rehabilitation services.
As directed by.
Right, well, then it goes
supervising veterinarian.
Well, then it went under the supervision piece. I was just addressing your practice versus performing or providing.
Dr. Waldman?
Something that's somewhere in the Practice Act, and there will be several people here that will know where, but I don't know where, is the definition of a range setting. And I'm proposing that we differentiate a range setting in RVT's tasks versus just a direct supervision. So something along the lines of, the task, or this task force recommends that RVTs may perform, I need the P words Anne Marie just used, APR under a direct supervision setting, with the exception of a range setting, or someone could say that in a different way. I'm just trying to incorporate both ideas.
I have not on the merits, or that we have kind of a motion by Ms. Heller here, Dr. Heller, I'm sorry. I'm just curious, before we go too much farther, perhaps we could get a second on that, and then we could sort of entertain some of this, back and forth. I suggest that. So I think we have a motion on the floor. I think it's up to this body whether there's a second that's brewing.
The motion was pretty rough, so I'm not.
Reread it?
If you were able to get some language out of that mangle, yes, please do.
RVTs performing animal physical rehabilitation must have additional training in animal physical rehabilitation to provide services under the indirect supervision of a veterinarian. RVTs who do not have additional training in animal physical rehabilitation must work under the direct supervision of a veterinarian. Was that the gist?
think so.
Second.
Did we second? Okay.
So there it is.
Members, now would be the time if you want to entertain discussion about friendly amendments or other ideas or other, now would be the time. And if without that, then we would exhaust task force comment and move out to public comment.
Dr. Walden?
Okay, I'm going to say the same thing, but in the more official way. I would propose a friendly amendment that instead of indirect, you could change it to range. Direct or range, I guess, if you could read it in a certain way.
And if somebody can show me that, I'm really happy to look at it. I just don't, like you, I don't know where it is, so I don't know what it looks like.
It's in MSM. I'll read it.
2038?
Yeah, I wonder if
I left my book at home.
Dr. Schlachter can, if what they're proposing and applying it to your situation, the RVTs on your range would be performing animal rehabilitation in an indirect manner. So the requirement is going to be made that those RVTs have additional certification. And you spoke of economic concerns with that. Is that going to still apply? Okay.
Sorry.
Yeah. Do we have a definition of range?
Well, I know it's in MSM.
We don't.
Okay, there is no definition.
Well, it's in MSM.
The range setting is in the process of part of the premise discussion that MDC is undertaking right now. So we do talk about in the MSM language, the chiropractic language, in the general, the supervising veterinarian shall be in the general vicinity of the treatment area when the animal patient is in a range setting. But we've not defined range setting yet. And we used to have an old definition. We just need to bring it back. But also, what's general vicinity?
30 miles.
Okay. And
Usually what it is when we talk about.
What is it, 30 minutes?
30 miles, yeah.
and this has been motioned and seconded, right?
It has.
Yeah.
Okay. So what's additional training? Is that, I mean, what's that mean? How have we helped the consumer? Because we've actually really said nothing.
I thought the motion used the word certification. Okay, sorry, just to clarify.
Can I respond? I think we went with additional training precisely because we were concerned about too specific language that would forestall future mechanisms for getting additional training. I also don't think we have to have perfect language today because this is going to go to the Vet Med Board for review and probable alteration. I think we're providing a guideline to the Vet Med Board. So I think what we're offering to them is this task force's sense of what we would like to see, and that additional training can be clarified at some future point. We're trying to leave it kind of open on purpose.
And I appreciate that, but there just kind of seems to be this undertone of a fundamental mistrust that veterinarians can make good decisions on behalf of their animal patients in terms of who may or may not do these procedures. And this is how it's been for a long time. So, I mean, I've never heard this in all of the years that I've been involved with organized veterinary medicine until we got to this issue. And suddenly the competence of veterinarians, not only to perform certain procedures, but to choose the people that may help them, collaborate with them, is all being challenged.
Kristen?
This additional training are we talking about, I just want to be clear, are we talking about additional hours of continuing education above what is required for licensure for an RVT? Or is it expected for it to be embedded within our current CE requirements? Because that could, cost would be.
I think the presumption would be additional training above and beyond the standard RVT curriculum. Otherwise, it's not additional.
What I mean, when we renew our licenses through the state, we have to submit our CE requirement.
And I think we haven't specified whether it would be via CEs or certification programs. That's where we're being general in order to avoid being too restrictive.
So you're basically saying let the board figure it out. Okay. Carry on.
In answer to Dr. Klingborg, I would just like to offer the thought that it's similar to what I've said before, that in an age where the concept of healthcare and medicine is expanding and beginning to take in and collaborate with other licensed professions or other activities, other modalities, I don't think there's any embarrassment or should be any distress that veterinarians would not be competent in everything. You guys aren't perfect. You're not. It's not required that you be all-knowing. And I think at this point it is okay to say that there may be additional training or that you can share some of the responsibility or things like that. It's just our healthcare model is changing for human medicine, and the healthcare model is inevitably changing for veterinary medicine. It's the consumers are doing it for you, whether you like it or not, because we're going to additional practitioners. I don't think it should upset you. I think it's just a point of understanding that the world is changing. That's all. Thanks.
I completely agree. I think that medical knowledge was doubling every 7 years, and now it's every 2 or 3. We actually have a tool right now, the way the Practice Act is written, for veterinarians to collaborate with physical therapists. And they come in under direct supervision as veterinary assistants. So that tool right now is in place, and it works in a couple of practices over here. These 3 individuals over here use that tool, and it has been a good model. We're here today because what we've heard is it's not good enough. I mean, that's why we're here today, because we've been having this conversation for years now. And there are people at this table who feel that that's not good enough. Okay, so this is good. We're finally to the meat and the potatoes of the issue. So what is good enough? Because apparently working with a veterinarian in a hospital setting under direct supervision isn't good enough.
Well, as I just said, that any educated consumer, which I try to be, can recognize that we can't hold a veterinarian at any level of practice, beginning or very experienced, totally responsible. Not only are we responsible for our animals, but so are you. And I would not expect you to know everything, and by the same token, I would not demand that a veterinarian, general practice veterinarian or newly out of school because of experience, would be expected to be able to train and supervise other personnel. Because I would expect someone who's at a practitioner level, the next level up is teacher level, especially, I come from sort of a Asian philosophy that you step up. You're the teacher, you're the master, so that if you wish to supervise and teach, that you would have additional training. Now, I think that's where you're perhaps feeling vulnerable, that it's okay not to come to need to work a little bit to get to the master level.
Might I suggest?
No insult intended.
I'd like to ask for public comment at this point.
Grant Miller, equine practitioner. So in considering the motion that has been made before you, my understanding is that the additional training is to take place after the core RVT education, and that additional training is not something that would be peppered throughout general continuing education. It is something that is concentrated solely on animal physical rehabilitation. That's my understanding of it. And if that is the understanding as we move forward with the vote, I would like to implore at least 2 of these task force members to recuse themselves from voting because they have a conflict of interest. They would stand to directly monetarily benefit from a certification program due to their stature. Thank you.
Holy cow, I'd like legal counsel to address that.
Well, not knowing the circumstances, I'm a little bit back on my heels. I don't know exactly if these are providers of these classes. If they are, then that pretend that would, in my mind, create a little bit of a conflict. There is some, public exceptions generally, but if you own or you're in the business of providing this class, you may materially stand to benefit. My advice would be, at least at the outset, that you seriously consider recusing yourself, so that there's no real or appearance of a conflict of interest.
Any other comments or questions from the public? Then, hearing none, I would like to call for the vote.
I have a comment, if I may. I would wonder why the request to recuse would not also extend to anyone who is providing this service, because they will benefit by allowing assistive personnel to assist in this delivery of services. So I wonder where that arm stops reaching out.
So I guess if as chair, can I just say I'm not going to require anyone to recuse themselves, and let's just call for the vote.
Sure. The motion? Mm-hmm. Okay, go ahead.
RVTs performing animal physical rehabilitation must have additional training in animal physical rehabilitation to provide services under indirect supervision. RVTs who do not have additional training in animal physical rehabilitation must work under the direct supervision of a veterinarian, and if we're taking the friendly amendment, or within a range setting as defined in regulation. Yes? Yes. Yes, Shala? Yes? No, I mean, is that, you seconded the motion, so you have to agree. Okay. Okay.
So it's a change from what currently is.
Yeah.
Because currently, the veterinarian decides.
Right.
But now we're making the change that's saying that if they don't have extra certification, it must be direct. Mm-hmm. And if they have additional certification, they can training, they can be indirect. Mm-hmm. Okay. Call for the vote.
Okay. Dr. Nunez?
No.
Lee Heller?
Aye.
Dr. Klingborg?
No.
Karen Atlas? Sandy Gregory?
Yes.
Kristen Hagler? Dr. Holland?
No.
Dr. Schlochter? Dr. Troy? Oh, sorry. Dr. Sims?
Aye.
Dr. Van Dyke?
Aye.
Dr. Chow? No. Dr. Waldman? No. Thank you. Shala Bar? Bill Gage? Aye. Carrie Ann Calais?
Yes.
Valerie Fenstermaker?
No.
And Leandra Clark Harvey? No. Okay. Let us count.
Oh, fiddlesticks.
Okay. We have a 8 to 10 or a 10 to 8, no.
You two have that?
Yeah.
Yes.
John?
Anyone else have a different count?
I had 9-9.
Jesus.
Okay, so,
But it's a tie is a no.
yeah.
We didn't get the failure to require the affirmative number of votes.
So
It's,
Okay.
okay, so 8 to 10, okay, or 10 to 8, no.
I would encourage members of the audience to count all the votes as well.
I think the motion may have been for additional certification in mathematics.
We did fine.
It's also being recorded too, if it really gets to that. So the motion does not carry. And unless anyone wants to keep at this, I would suggest that we move on to veterinary assistants.
Can we, I'd like to actually offer a motion on this, and that would be that RVTs are allowed to perform animal physical rehabilitation under direct supervision unless in a range setting. RVTs, right? Unless in a range setting, in which case it would be up to the veterinarian to decide. And furthermore, would like to add this to the job task list of RVTs.
Second. Okay, wait a minute.
RVTs will be allowed to perform animal physical rehabilitation under direct supervision unless in a range setting. And in that case, the veterinarian, the supervising veterinarian, is allowed to decide the appropriate level of supervision. Furthermore, I would like to add this to the job tasks allowable for RVTs. And there's a second.
So physical rehabilitation will be added to the list that only RVTs can perform?
I think with Dr. Klingborg, if I may, your 2036 spells out what the healthcare tasks are. You would want that to be enumerated, APR to be enumerated there, correct?
That's correct.
But under which?
I'll try that again for those of you who are paying attention at home. That would be that Dr. Klingborg, part of his motion would be to add APR to section 2036, the animal health care tests that be provided by an RVT.
Okay, the only problem is you have that sectioned out between direct and indirect, and this motion covers both. So when you're saying you're adding it to a list, I mean, this is really the mechanics of it, and we can figure out the mechanics, but just know that they're already separated out by direct and indirect, and this motion spans both. So
Correct, but I think
the mechanics we'll have to figure out.
It does. I mean, we can move it and create it as D, and then we can turn D into E and
logistical thing.
Oh, I see.
Any board? You mean task force comments? You're going to ask for task force comments? I have it over here.
Yes.
You want me to ask for task force?
Yeah.
Okay, comments from the task force about the motion? Okay, thank you.
Other than I just wanted to reiterate that under the previous language that we were trying to agree upon was that with my additional training, that if that was passed as a regulation, that would mean that I could go open out a rehabilitation center because I have advanced training. Is that what we had previously? Okay. That with the indirect supervision.
No.
Okay, I was just trying to clarify for people.
I mean, this is kind of off topic, but you can't be an MGL of your own practice. So,
right.
And you'd be practicing veterinary medicine.
Okay, good.
Okay.
That's good. Thank you for the clarification.
You're welcome.
Okay.
it's not the excluded task.
So it is tasks that can be performed.
Mark?
Yes.
So just a question about 2036, if it becomes an RVT test, does it then prohibit a veterinary assistant from doing it under 2036.5?
That's how I read it.
That wasn't my intention. So
That's the question.
it's a good question. So perhaps that last sentence would need to be removed. If we want to simplify life, we could remove that and say, simply RVTs may provide animal physical rehabilitation services under direct supervision unless in a range setting, in which case it is up to the supervising veterinarian to decide the appropriate level of supervision. And, okay. And then we'll leave the task thing alone. We got people out there.
Any additional questions from members of the task force? And any comments from the public?
Just trying to get my exercise for the day. Grant Miller, equine practitioner. So when you state that, it's implied that in a range setting you're talking about large animals. And I'm just wondering then, why would the degree of supervision for a competent individual be any potentially less in a range setting than it would be in a hospital setting? So in a hospital setting, you're saying it's direct supervision only, which is somewhat restrictive, versus in a range setting, it's either or. Why don't we just make it either or at the discretion of the veterinarian, at the supervising veterinarian? Thank you.
Additional questions from the public? Okay, Shala?
Correct me if I'm wrong, I feel like we're getting off task about how this creates protections for the consumers and their animals. It seems to me that this is creating convenience for the vets, and I'm not against that at all, that's fine. But I just don't see how this is proactively helping consumers.
It's making it, there's additional restrictions that are being placed on RVTs now than what currently is. They need to be under direct supervision now, whereas before it was under the discretion of the veterinarian to make that call. But we're making it more restrictive. We're not making it less restrictive with what we're proposing. He's making it more restrictive.
Currently, the status quo is that the veterinarian may decide, because this particular task is not clearly spelled out in the Practice Act. The veterinarian may choose the appropriate level of supervision, so it may be direct or indirect. This language creates direct supervision unless in a range setting. And I'll explain why that in a second, but this is actually more restrictive. So this is a higher level of consumer protection. So why the range setting difference? Because I do understand the difference between the small animal population that is seen in the hospital setting and the kinds of health issues that they have running alongside their need for physical rehab versus the kinds of issues that large animals tend to have. And we're not seeing, I think, the same issues with bone cancer and so on and so forth in large animals, equine, that we tend to see in the small animals commonly with these. So that's why, because they are two different populations.
And it's not completely throwing competency out the window, because it's still under it's the responsibility of the equine practitioner to determine competency.
And we would assume that competency would not just be based on the individual that's providing the service, but also the particular case.
Okay, so it's been motioned in second. We had opportunities for the public, and if there's no other additional questions or comments from the task force?
Yeah, it does seem odd to me. I tend to agree with Dr. Grant that it does seem odd to me that we would now separate species out to figure out supervision levels. Can't something happen on the range that could also happen in the clinic? And so now we're picking apart, just because it's a different animal, now we're picking apart supervision levels for different animals. It doesn't seem consistent to me at all.
Dr. Walben.
I understand why you're saying that, Karen. There's just a lot of what we're all trying to do here is to create access. And in the large animal world, it's so different from our small animal world where all the patients come to us and we're all in the same tiny building and we're all able to be under the same roof. The vets are traveling in trucks and moving hundreds of miles during the day. And there's going to be a cost factor in their setting that's different from ours that I think would limit access. And so I think that's why I was thinking it would be a better idea to separate the two.
Dr. Van Dyke?
I actually like the concept of empowering the veterinarian to make this decision and to decide the competency of their technician in offering the service that they're recommending and deciding the level of supervision of that person for that task. I mean, it falls to their shoulders when we get to the liability issue anyway, that it's the veterinarian's decision. So I actually feel it makes more sense just to say it's up to the discretion, which is basically how our current practice act reads, right? So I don't understand throwing the additional layer of supervision on the small animal, essentially on the small animal side. I think it makes more sense to give the veterinarian that power to decide who they're going to have treat the animal and what their competency level is and what level of supervision they require.
It's weird for me because I feel like we've had this conversation about RVTs and they need to get this extra certification and veterinarians need to get this extra certification. And so I actually viewed this as a compromise because I agree. I mean, all along I've been saying I think the veterinarian, because ultimately the buck stops there in terms of liability, has all of the responsibility to make those right decisions. So this is an olive branch to direct supervision. If it doesn't work for you, I'm willing to amend that, but I would need my second to be willing to amend that. Okay.
Yeah, I'm a bit because what you just proposed is leaving it the way it is, not
Right.
making any change.
I still would love to see some overarching language that suggests all of us should pursue additional training if we're going to do cardiology, if we're going to do whatever, and that specifically we're a task force discussing animal rehab. I'd love to see everybody say, you know what, we need to learn more about this rather than just assume that we can buy equipment and use it.
Right.
So that being said, when it comes right down to the nuts and bolts of working within the practice, I don't think it's fair to paint the veterinarian into the corner saying, now, if you're going to do this, you have to be directly supervising that technician. If they feel, A, fiscally, this is not going to work for me, and therefore I am not even going to offer rehab, and B, it seems inappropriate for me to have direct supervision over someone I know knows what they're doing. So I'm here from supporting the veterinarian, but also looking at this from our ability to offer this to the public. If we make it fiscally irresponsible to do this, no one's going to do it.
Chairman Inez? I think maybe this might help clarification. Direct supervision doesn't mean the veterinarian has to be in the room. It means on the premises. So I don't know if that helps you in terms of this concept. So it's not saying that two people have to be in the room. It just means that with the exception of the range issue, the veterinarian needs to be on the premises, which is normal RVT practice for most of what an RVT does anyway.
Right. I just would like the veterinarian to say, I had to run to the bank. I still have my technician doing the work, right? I stepped out of the building. I'm not going beyond what I'm allowed to do with my practice act.
Okay. It's 4:15, and I'm going to call for the vote on the motion that has been made and seconded.
Could you restate it?
Do you have the language?
Could you read that again, Anne Marie?
The same motion, we haven't changed it.
Correct.
RVTs are allowed to perform animal physical rehabilitation under the direct supervision of a veterinarian unless in a range setting, in which case the supervising veterinarian may determine the level of supervision.
Call for the question, call for the vote?
Okay. Dr. Nunez.
Yes?
Lee Heller.
Aye.
Dr. Klingborg.
Yes.
Karen Atlas. No. Sandy Gregory.
Yes.
Kristen Hagler. Yes. Dr. Holland.
Yes.
Dr. Schluchter. Yes. Dr. Sims.
No.
Dr. Troy. Yes. Dr. Van Dyke.
No.
Dr. Waldman. Yes. Dr. Chow.
Yes.
Shala Bar.
Abstain.
Bill Gage. Yes. Carrie Ann Calais.
Yes.
Valerie Fenstermaker.
Yes.
Leandra Clark Harvey.
Yes.
Okay.
What is the official count?
The precincts are still reporting.
14. Do you have 14? One abstention.
14.
And there's how many people? 18 total, yeah.
Yeah, one that set it out.
3 no's.
14-3-1?
Yeah.
14-3-1.
The motion carries at 14-3 and 1 abstention.
Yeah.
This task force has more plots and turns than an M. Night Shyamalan novel, huh? Jeez. That, veterinary assistance.
I'd like to make the motion that veterinary assistants may provide animal physical rehabilitation services under direct supervision. Second? Of a veterinary, yes. Oh, that's a good one. What would you like? Yeah, yeah. Okay. Under direct supervision of a veterinarian or an RVT. Val, you still on board? Second. Okay.
Then the RVT is under the supervision of the veterinarian, correct?
So it's been motioned and seconded that that veterinary assistants be allowed to perform animal rehabilitation under the direct supervision of a veterinarian or RVT. Any questions or comments from members of the task force? Any questions or comments from members of the public?
Did we have a second?
Yes.
Valerie. Val. Okay.
Hearing none, then I will call for the question. Vote.
Dr. Nunez.
Yes.
Lee Heller.
No.
Dr. Klingborg.
Yes.
Karen Atlas.
No.
Sandy Gregory.
Yes.
Kristen Hagler. Yes. Dr. Holland.
Yes.
Dr. Schluchter. Yes. Dr. Sims.
No.
Dr. Troy. Yes. Dr. Van Dyke.
No.
Dr. Waldman. Yes. Dr. Chow. Yes. Shala Bar.
No.
Bill Gage.
No.
Carrie Ann Calais.
No.
Valerie Fenstermaker.
Yes.
Leandra Clark Harvey.
No.
Ten.
10 yes.
10. The vote's 10-8, so the motion carries.
We have 2 more categories to go through, physical therapist and physical therapy assistants. I recommend a 10-minute break at this time. All right. So let's reconvene, and we would love to try to wrap this up by, at the latest, 5:15. If we can wrap it up by 5, that would be even better. And I think that there's two other issues we have to address, and that's physical therapist and physical therapy assistants. So would anyone like to make a motion, perhaps?
I'd like to make a motion. I'd like to move that physical therapists may provide animal physical rehabilitation services under a level of supervision that the veterinarian decides in a hospital setting or on a veterinary premises, however you want to put that.
Can I ask for clarification? Would that provide an opportunity, if we were to make that decision, for a physical therapist to hold a premises license? Or is it only a license that was held by a veterinarian?
The premise, that's a whole different conversation. I mean, I get it, but the premises, we have not addressed the issue of a premises being held by a non-DVM.
So the gist of your motion is that they would have to practice at a veterinarian's office?
They need to be in a hospital setting, that is correct. Yeah. But I think the other part to that motion is I recognize the education of physical therapists. And with RVTs, we've just passed language that required direct supervision in the hospital setting. And with physical therapists, we're not mandating direct supervision. The veterinarian may decide indirect supervision.
Chair Nunez, I don't want to interrupt the motion process, but I want to point out that we started out with veterinarians looking at their educational training, and we seem to be jumping into a motion without doing the equivalent for physical therapists.
We did.
So,
yeah. The reason why was in an attempt to see if we can wrap it up, because I think that during the course of the entire day, all of us has thought about the educational requirements and the level of supervision for all 5 categories. It's not.
I don't feel that I've been given that information where physical therapists are concerned.
Okay. So it's been motioned and seconded. And I acknowledge that I did go into warp speed to do that, to achieve that. But are there any questions or comments from the task force?
I'm not sure if I should amend it, or can we put in something about a range setting? Again, from that perspective, because again, I work with PTs that I would love to be able to send out on a lame horse to do physical therapy that I've prescribed.
Yes, so we could say veterinary premise or in a range setting, the supervision is still decided by the veterinarian. Yeah.
Lee?
I'm really uncomfortable with the fact that we're not taking the time to talk about the training that physical therapists have, because that should determine our decision about what level of supervision they require and in what settings. We're here to try to have a pretty significant conversation about an area of practice and an area of practitioner that I think a lot of us don't know very much about what their training is and what we know. And I feel like we're just jumping past that. We have not talked about the PT curriculum. We have not talked about training and recognition of injury, wound care, about their education and when to refer back to the referring veterinarian. And this feels to me like it violates the spirit of what we are here to do today.
So if I may respond to that, I am not in any way, shape, or form trying to diminish the education of the PTs. But Karen, I read all the attachments you sent, every single page. And I would imagine that everybody else that's sitting at this table did too. And in that, we had several programs that talked about the physical therapy doctorate, all of the education, some really disgusting slide sets of people with various ailments. It was all there. So we've had the opportunity to do that. And I guess I would ask, is it going to change how you feel about this motion? I'm not sure. That to me, really, that's the crux of the issue here.
In fact, it's very entirely possible that it will change someone's mind. The whole point of this is a conversation. Otherwise, we could just sit at home and call in our votes. The point of meeting as a task force is to engage in a conversation, to explore the material and the issues, to provide the public opportunity to assess our conversation and those materials, and for the public that's watching to understand our process. That's what open meetings are about. This motion circumvents the spirit and, to my understanding, the law of the open meetings process.
Just a point of clarification, if I may. I totally respect what you're saying, but just because we have gone out of order in terms of providing information and then taking a vote and switched it to having a motion, we still have a discussion period within which we can have the discussion that you're so direly advocating for. So,
oh, no, I understand that, Leandra, but
abdicates.
An opportunity was provided for the veterinarians to present about the curriculum at Davis and Western. No opportunity was provided for the physical therapists to present about the curriculum that they undergo.
And I guess
So it's not an equivalent process.
And I think that the opportunity still exists. And legal counsel, if you would step in and confirm or disconfirm.
Sure. Legal counsel has a couple things to say. More than a couple, actually. I think it's within the want of this body if they want to dispense with kind of the protocol that was laid out when we tackled item 7 and 8, when we decided that we were going to go through the five affected licensee types, hear from the education, their experience, the level of supervision required, and then tackle perhaps some other things about the premises. So I think that if the board wants to dispense with that, it can. I would say that there is a little bit of concern that I share with Ms. Heller in that it seems odd to get essentially 3/5 of the way done and then suggest that we're going to make a hard left or a hard right. So there's that. I do want to point out, and maybe pardon me if I step out of line. It was my understanding that when the question about education, certification, additional specialty was suggesting that, and I'm not physical therapy's counsel, but there was some physical therapists that would be sort of authorized to perform animal rehab if they have the additional certification. And I'm just curious, is the motion, as I understand it, seems to suggest that any physical therapist. So is that, am I off base there? I just, took a little chemical holiday or what? So.
That is how the motion reads.
Okay.
Yeah.
Yep. Gotcha.
So
okay.
It would be different than other states have done.
Okay.
It would be the California's.
Yeah, I'm not a board member, so I'm going to be quiet.
Let's.
Yeah, if I may be allowed, and obviously you can do all the reading you want ahead of time, but still, even today, there's significant and egregious misunderstandings about the practice of physical therapy. As a public member came up here and said some very disingenuous things, and apparently is rather naive about what the current practice, contemporary practice of physical therapy is. I came to the CVMA back in February 17th of 2011 and presented there. And so it all started back then, John, if you want to think of all the time. I tried educating individuals who are involved in this to let them know what physical therapist does. And the contemporary practice physical therapist, rhetorically I ask how many of you folks have been into a physical therapy clinic or received physical therapy, because you kind of call it range of motion, passive range of motion. And that's really not skilled professional practice. And a physical therapist is doing a lot more than that. And that's why when we identify the term physical therapy and animal rehabilitation, I have almost 2 operational definitions in my head for that because of the critical thinking process that the physical therapist does. It's so much more of the diagnostic process that we are obligated to participate in. We have a plan of care. It's regulatory required, and the plan of care is based on and subsequent to a physical therapy diagnosis. And so we do diagnose as much as the medical field thinks that we don't within our scope of practice. Essentially a 4+3 curriculum. I will address kind of the specifics in terms of an earlier person make a statement about physical therapists don't know anything or don't participate in anything about the pain. There's actually a whole class at Loma Linda University where I teach called pain management. And so it's very disingenuous for the person to say that we do not know how to treat pain. Pharmacology, pathology, physiology, basically many courses that we have that address pain. The other comment that we have, and that's on number 25 of our packet, on page 12. You look at Loma Linda's curriculum and have that. The ability to identify tendon pathology was specifically identified as a skill set that we do not possess, and that we are unable to order or perform ultrasounds. That is definitely not true. That is, in terms of fact check, that is false. We have 3 machines. We teach it in our curriculum at Loma Linda. At Loma Linda, we have clinical imaging class. At USC, they have orthopedic radiology and clinical imaging also. There's principles of diagnosis of disease process also, and the pharmacological interventions going on with that. The other one was our inability, apparently, as he is said to have stated, of ability to work with communicative people who, animals that can't communicate. Well, you ever try working with a receptive or expressive aphasic stroke victim, you recognize the physical therapists are well trained to work with a activity with a patient who has the inability to speak or to even receive information. As a matter of fact, it's not the inability to receive, but they receive it wrong. And so we get trained in that. Our ability for wound care in terms of the intensive care unit and working, you saw some of the slides from the curriculum from USC in terms of that. And so it was funny, and I'll just conclude with that. One of the previous members on the MDC said, I've never been to a PT clinic. I don't know really what's going on. And so I think there has been an attempt to learn more about what physical therapists do and what we bring to the table in terms of our diagnostic and the doctoral level, graduate level training that we receive. And there's also one person in the full board that said, regarding when there's a discussion about direct supervision, and the vet on the board said, what? I wouldn't even know what I'm supposed to be supervising and such that. So it was amazing to see the lack of knowledge about what physical therapists do, yet people make decisions on that. So I think that that's where our curriculum has gone. Now, the last comment is that realize that the physical therapist graduate, I've been asked, how much anatomy do you get in animals? In my entry-level program, I don't. But in the qualified physical therapist that the interest in physical therapy have here are those ones who've had additional training of animal pathology, animal anatomy and such. So that physical therapist that is qualified to serve and treat these patients and safely.
Okay, so as Leandra had predicted, this is the physical therapist talking about the education and training they receive. Just one really quick question. That whole list of training, that is for specifically humans, or is it for animals?
As I said at the end there, this was the entry-level physical therapy training, which is in the human vertebrate, not the animal vertebrate.
And then, but there is an opportunity for physical therapists to learn all those things on animals, but that's additional training.
And I'll defer that to Karen Atlas.
Okay. But the proposal that has been made by Dr. Klingborg is that we are going to allow physical therapists, who has received all the training on humans, and he is not proposing that they have the additional training on animals. It's a pretty controversial motion, but that's what it is.
Yeah, I think it's irresponsible to allow a physical therapist to do physical therapy on animals without additional training. It is different, and to just put them under direct supervision or indirect supervision, or either way, you need to know what you're doing before you do it. So I think that it's critical for a physical therapist to go to get additional training, and that's where we learn a lot of what we do in terms of referring things back to veterinarians when something isn't right. We have the ability to recognize when things are not going right, and so we refer them right back to their veterinarian. We're not veterinarians, so we're trained to recognize when things are not going right, so we refer them right back to the veterinarian. Same is true for wound care. So if you have this, we've been trained in wound care, but we don't even, for this topic of conversation, all we need to know is whether a wound looks like it's in bad shape or not. So then we just refer it back to the veterinarian. So all we have to do is recognize what our limitations are, and then we refer them back to the veterinarian. So have I think that it's important to, this is about consumer protection again and access. So, to mandate advanced training in the form of certification or however you want to call it is important and critical, and to allow for access if we are well trained in knowing what our limitations are and recognizing the problems that could come up. So we refer them back to the veterinarian. So to force the issue to be on the veterinary premises is far too restrictive, I think, and would limit consumer access and would limit the amount of physical therapists that would go into the field in the first place, because they would be so limited in their career and be reliant on a veterinarian to hire us, when they may want to hire a maybe less expensive or less trained technician, which is now allowed to do. So to force the issue to have it be on a veterinarian premises is far too restrictive in terms of limiting access. I think it's restraint of trade, and then we get into the problems of the North Carolina Supreme Court case.
And then just to finish that, what are your thoughts on direct versus indirect supervision?
For physical therapists?
Yes. You said that they should have additional certification.
You should have additional certification.
I
am comfortable with the vet having the decision whether they want to do it, but I don't think it needs to be mandated to be on a veterinarian premises.
Yes. But then as far as direct versus indirect, what are your recommendations on that?
My recommendations would be indirect with a referral or a veterinary medical clearance. As we looked at all the other practice models that we know work and that we know don't have complaints after 70 plus years, and it's been proven, it's been shown to be safe after 70 plus years, and it's unnecessarily restrictive to mandate to be on a veterinarian's premises. And I know, and we don't need to stay within the regulatory language here. We're tasked to come up with the best language for the consumer. So if it's going to take a statute, then it's going to take a statute to be able to make it work. So I don't think we need to be in the confines of the regulatory language that stands now. I think that we need to look for protecting the consumer with proper education for to show competency by the practitioner, and then to allow them to practice off-site because we have the knowledge base of being able to refer right back to the veterinarian, which I often do, which I do all the time, and it's been shown to be safe, and there's no reason to mandate on-premises veterinarian.
Lee?
So when we come back to the consumer protection issue and the access issue, I think there's a difference here that the current motion doesn't provide for that I would really like to get at. So what a lot of us have been saying all along is that a traditionally trained physical therapist with no additional training in animal physical rehabilitation should not be practicing without direct supervision. They know a lot about physical therapy, but as Dr. Sims has said many times, he doesn't practice on animals and doesn't feel competent to do so. But a physical therapist with 4+ years doing wound training, integument understanding, recognition of all the things they can't treat and need to refer back to the veterinarian, and additional training in animals, particularly dogs if we're talking about limiting it to canines, because that's another issue. To restrict that person to a veterinary premises is going to make it nearly impossible for people who do not live in urban areas and have access to the Dr. Waldmans of this world to have access to that service. So I think the critical component in all of this is the veterinary referral. okay? So the veterinarian needs to assess and diagnose and determine. I've read the examples that Dr. Waldman and Dr. Troy have brought out. If you have an animal that is too fragile to be in a physical therapy setting without a veterinarian, that animal shouldn't be sent to a physical therapy setting that doesn't have a veterinarian on the premises. And that should be the veterinarian's determination. But every animal I have taken to physical therapy has not been in that circumstance. And I don't live in a big city. And if you require even highly qualified practitioners equivalent to the CAAPT membership to only practice on a veterinary premises, you are going to deny the majority of consumers in the state of California access to a service that the practitioner is qualified to provide.
Dr. Troy, and then Dr. Klingberg, and then Carrie Ann.
Lee, I understand where you're coming from with access, but my concern is higher than access, and it's safety. And its continuity of care. And Karen mentioned how she sends a lot of patients back to the referring veterinarian, and I'm sure that's an appropriate thing to do. But in my practice, I walk down the hallway. When I have a dog with where the splint is taken off and looks like this can't be put back on. If this were in a facility without a veterinarian, this splint cannot be put back on. This dog had gram-negative and gram-positive rods floating around in this. How do I know? Because I did a cytology in-house, and I looked at it, and I did a culture, and I put an appropriate bandage and splint back on, and we didn't do therapy on him that day. But had he gone into a facility where there was not a veterinarian, this dog who'd had Achilles surgery would have had to limp out of that facility, call their veterinarian, make an appointment, hopefully the same week, and be seen. And that lack of care would have caused this dog to suffer. I've had a dog go down in my tank. She was standing there. She was an osteosarcoma patient. She had to have x-rays taken, and she was euthanized. That family would have been devastated if that had happened in a facility without a veterinarian on site. That dog would have suffered immensely. No, I don't see him every day. The histrionics that Dr. Van Dyke pointed out are not that in my practice. I don't know, maybe I'm unlucky, but I've got picture after picture of cases that could not be managed without a veterinarian on site. My neuro patients that come in that are barely walking, that have an indwelling urinary catheter that falls out. Could that dog then be carted off to its veterinarian? Sure it could. But how is that fair to the client and to the patient? How is that fair to that client who has just gone through this major surgery with their dog, who is not walking, who is, by the way, 120 pounds? So getting that dog in and out of the car is not easy. When I can walk down the hall and place that Foley back in that dog's bladder and give that dog the relief that it needs. That's what we do in veterinary medicine. It's continuity of care. It's providing for those, oh my goshes, I didn't plan for it, versus the relatively easy orthopedic or obesity or the patients without complication. I spend my day worrying about the patients with complications. Thank God they don't happen all the time in general practice or rehab. But when they happen, I owe it to that client, and more importantly to that patient, to be prepared. And that's my concern about not having this on a veterinary premise. This is a practice of veterinary medicine. And to have it outside of a veterinary premise, to me, is a disservice to the patient and is giving false sense of security to clients. Clients aren't going to walk in knowing, okay, I know you can't do CPR, I know you can't put in the Foley, I know you can't do this. Most clients walk in thinking we can do everything, which is a whole nother challenge that we have. But veterinary medicine should be under the roof of a veterinary hospital.
We're going to go to Dr. Klingberg and Carrie Ann, and then.
So I'm more than willing to accept a friendly amendment to stipulate that the PTs have the certification that we're talking about. So anybody who wants to make that friendly amendment, I'm all for it. The other issue we have here is that if it's not a veterinary premise, the Veterinary Medical Board cannot inspect it. So again, we're talking about consumer protection here. And there's only inspection authority when it is a registered veterinary premise. So that's why that language is there. What's the facilities like? Is it clean? Is it safe, et cetera? That's why that's there. This, again, is a consumer protection question, not a bottleneck of care. There are over 3,000 veterinary premises in this state. There are a lot of them up and down the state.
Carrie Ann.
Thank you. I have two points. The first one is how many veterinary hospitals can afford to install an animal physical rehabilitation facility? It's a financial burden and a liability burden. It must cost a lot of money. Well, okay. We'll see if people can do it. My second point is that we didn't follow up on Dr. Heller's reservations about completing this task of ours so quickly by, compressing what's the time available for discussion of physical therapists and physical therapy assistants. I can speak as someone who is one of the many hundreds of people that wrote in comments, attended the hearings in September last year, attended in October, and all, et cetera, et cetera. You've got hundreds of people who could be watching this, or they will be learning of this. This whole business where the issue at hand is pushed to the end, if there's any way we can have another meeting, people are going to say, wow, the board did it again, that they pushed everything to the last minute and the physical therapists didn't get their say and blah, 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 blah. I'm talking about public perception and the fact that you got bushels full of reaction from the public, online petitions, letters sent in, people coming to meetings. I agree with Dr. Heller, and surely the deadline could be pushed back.
I'll go with Dr. Van Dyke and then Val.
I'm coming back to this notion of death and disaster happening in rehab practices all the time. So in the case you have of the Achilles dog, who removed the splint?
I did.
Right. So if it was at a PT's office, they would have said, you know what, I'm not going to remove this splint. You need to go see the veterinarian to do that. At which point they're in the veterinary hospital determining that there's something, being able to take that next step. So, I see a lot of this where it's like, here's another, drama and pictures, but with all due respect, the PTs who are trained, and that's what we're recommending, is that only PTs who are trained do this, recognize red flags. They recognize these issues. Dogs dropping dead in the underwater treadmill, with all due respect, if we look across the nation and poll all of the people doing this, a rare occurrence, and most of those dogs are, there's an indication going in that they shouldn't have been in that treadmill. They also could have dropped dead on the street on the way to the groomer. So I just think we have to, kind of keep in mind that this is not something where we have this horrific problem of unsupervised PTs just running roughshod on our veterinary patients. I think that they have a tremendous skill set when they have the additional training, and that we go back to it should be up to the veterinarian to determine the level of supervision per case, per event. They can determine this is not one that I want to have outside my practice today. So I'm a strong proponent of empowering the veterinarian. I'm also a strong proponent of recognizing the skill set of the PTs who have taken the time to get the additional training.
Val?
I just want to say I think there's a big difference between training and education. A 12-week course to be trained to do physical therapy on animals versus a 4-year education on humans, treating humans as a physical therapist, is far different from a veterinarian who goes to veterinary school. That's what we spent all of that time discussing, and that's the difference between what veterinarians are and what physical therapists do. As I see it, if we go down this road of not including veterinary supervision, there's a huge slippery slope here. What stops any other profession trained in human medicine to say, I can go take a 12-week course on animals and open my own shop? I don't think that's consumer protection in the least, because that's what's going to be next. So I don't think that not having veterinary supervision is in the best interest of the consumer. I've heard everybody at this table for not the entire 10 years I've been a part of this, but I've heard many of you, and I've yet to have my position changed because, as we said before, veterinarians have this all-encompassing
understanding of the animal patient. And I would entertain the fact that a physical therapist does not. And when push comes to shove, the animal is the one that we really have to care about. And I strongly feel we have to stay in an animal hospital setting.
Dr. Waldman, Karen Atlas, and then Sheila.
Because there's no animal training in the PT curriculum and in the certification courses, there also isn't training in animal safety. I find it really super, super scary, especially because I work with physical therapists with the additional certifications we're all asking for, to have them on a premise by themselves. I treated a golden retriever that the PT treated before me one day who said, he seems tired today. And I checked him and he had a hemoabdomen or blood in his abdomen and was bleeding out. And the PT, and I would never expect them to, weren't able to identify shock, heart murmur, heart issues, all the other things when they thought, gosh, that pet just seems tired today. And I recognized a million problems. They aren't all impending doom and death. Some of them are, for sure, every few weeks. But they're medical issues, they're medical ailments. And the other thing is, because we practice as veterinarians and physical therapists together, the PTs have easy access to us. We are asked questions medical questions by the PTs probably around 40 times a day. Okay, if they don't come to us and ask those questions, they're going to send back to the regular veterinarian and the people you think are going to go that often for those little questions. That, to me, is more expensive than having a vet right there and answering all those questions for you. Another concept is that veterinary insurance. So we're talking about access here. We're talking about cost structures. Wow, this is a major deal here. I passed out in my really long handout I gave everyone. The first page is a chart that talks about if veterinary insurance covers veterinarians or other people that practice rehabilitation. Well, all the insurance companies today cover veterinarians, and 7 out of the 11 of them exclusively are covering veterinarians alone. So if you're a physical therapist and you're practicing, you're not covered. And I can tell you right now that I have a giant proportion of clients that depend on care because they have insurance that covers what we do. So that's another thing. When I read the letters that were submitted in the packet from Dr. Millis and Dr. Levine, the vet and the PT that worked through the University of Tennessee together, who are some of our industry leaders, and they very clearly state that both the veterinarian and the PT are in favor of direct supervision. And they're teaching courses on this, and there are leaders in the field, and they're publishing articles on this. And they say, why? That's how the PTs that I practice with say. And there is a letter also in my packet from a PT I work with that says, I don't want to do this without a veterinarian. There's been too many problems and issues, and I don't want that responsibility. So between the pet safety, which I have in my packet, many, many letters supporting medical ailments, issues, reasons why it was important that the veterinarian was on site at the time of treatment, between, access through insurance and our general responsibility, to our patient care. At the end of the day, the consumer is the most important, but to me, it's the pet. And there isn't any situation that I can think of where it would be better for the pet to not have a veterinarian on site.
Karen.
I'd like to bring up a few things. First of all, I think it speaks to the vet that is making the referral when they are making referrals for dogs that have foleys that could come out, or dogs that have big wounds, or dogs that have critical medical problems. They shouldn't be referring to a physical therapist then. They're not, that's why we want the veterinary medical clearance intact, the VCPR. We're not saying also, Valerie, that we want to work separate from a veterinarian supervision so that we're trying to separate completely from the veterinarian. We are just, we believe that we have the skill set, the competence, the ability to refer back to the veterinarian if we're not on the same premises as a veterinarian. And the critical dogs shouldn't be coming to us in the first place. So the vets should not be making those referrals. So I think that kind of speaks to the vet's decision on whether they're allowing that referral to go through. It shouldn't be referred over. In terms of the insurance, I see dogs every day that have insurance, and the insurance companies are covering it. And if this were to go through on a statutory fix, then it would follow the same way the insurance companies would follow. So I think that same with the malpractice insurance. We have malpractice insurance already, so that shouldn't be any sort of barrier there. And then I have several, high profile, whatever, celebrity dogs that come in and that have caretakers that take care of these dogs 24/7. They have RVTs that actually take care of these dogs. And then they come to me, and just about a month and a half ago, came to me, and I was doing my manual therapy and noticed a lump. And I said, this is not good. You need to go see the vet. Oh, do you think I need to see him right away? Yeah, I think you should go. I think you should go. It doesn't feel quite good. It doesn't feel quite right. So sent him back to the vet. Sure enough, it was cancer. And I found it. They're like, oh my gosh, thank you so much. I can't believe I didn't find it. And this is a dog that goes to the vet all the time. And this dog has a high level of care all the time because they have caretakers taking care of it too. So I think that we serve as an extra set of eyes and an extra set of hands to be able to recognize the problems and be able to refer back. So I'll not I'll leave it there for now.
From a legal perspective, we've been kind of granted, we sort of made a bit of twist and turn here. We started off with our 5 license types, and then we sort of, with our 3 areas within, and then we sort of got to 3/5, and then we sort of dispensed with it, and now we sort of re-entered. We have a motion and a second pending. We have the author of the motion crying out for an amendment. I'm sorry, Dr. Klingborg, I'm probably poor words there. So I think what we have had is we've had at least a topical discussion satisfying Ms. Heller's, perhaps that we have discussed a little bit of the education that are required. It's probably not the most comprehensive discussion that we could have had. But saying all that, what I would ask going forward is that we sort of, the task force sort of focus on what's in front of it, and that is the motion, the potential second of, the proposed motion, the sort of any potential amendments out there, and then we limit the conversation to that motion going forward, because I think we've satisfied the 2/5, or at least 1/5 remaining, which is the physical therapist. So,
Okay, so then what I would propose is that we read the motion with an amendment that the motion maker has said that he'd be willing to accept.
Physical therapist, the amendment is, with advanced certification in animal physical therapy, may provide animal physical therapy under the degree of supervision as determined by a veterinarian within a veterinarian premise or range setting.
And who seconded the motion?
Val.
And do you accept that as well? Then I'd like to just call for the question. Call for the
Public comment.
public comment.
yeah, one more per.
I just think it's important for me to let you know about what happened to me.
Turn on the mic, please. Yeah.
There we go. Thanks very much. My voice carries really loud. Let me know if I get too loud.
Before you begin, is this directed on the motion that we have in front of us?
I believe it is. It regards a dog that I have that I broke her leg on a Friday afternoon, spiral tibial fracture, oblique fracture, and my vet was getting ready to close. I needed to do something right away. I called the vet and said I watched my dog play on the beach and broke a leg. They invited me in. My vet was not there. I was referred to a different vet in the office who I'd never met. And they confirmed with x-ray that my dog broke her leg. And again, it was a Friday afternoon. Every orthopedic surgeon in a range of 4 hours was at a conference in the state of Washington. So they asked me if I would like to drive to San Diego, which was a 4-hour drive with my dog. That they felt that the dog should be taken care of right away. I was willing to do anything I needed to do. My vet was not on the premise that day, and I deferred. I'm a clinical pharmacist. I'm a infectious disease medicine. I don't do surgery. I've never worked in the surgery field, so I wasn't really sure what I should do. I listened to the veterinarian.
I would encourage you to make this relevant to the motion soon, or else I'm going to not allow any more.
All right. Well, basically, surgery was performed by a non-orthopedic surgeon. To make matters, I'll cut to the chase. In a 6-week period of time, my dog rotted off her metatarsal pad because the splinting was inappropriate. She had too large of a plate placed in her leg where the laceration did not close. And
like a case of medical malpractice rather than whether or not allowing physical therapists to perform.
Yeah, and so yeah, a physical therapist was called in by a different orthopedic surgeon, and I realize it's late. I can stop the story. We can discuss it later if it doesn't feel.
Just sum up sort of the punchline.
The punchline is that it was a year and 1 month for my dog's spiral tibial fracture to be healed. I had physical therapy that did cold laser to close holes in the bone. That were so many holes in the bone that they could not put another plate in. There was a non-union of the distal fracture that required a piece of the shoulder placed. The dog was placed in an external fixator after going through grand rounds at 3 teaching hospitals to determine that there was no chance of another plate being placed.
In this unfortunate case, the physical therapist was very helpful in recovery.
Very helpful. They did, by the time the dog came out of external fixation and splinting, she was completely atrophied. She had contractures of her foot.
Veterinarian?
Worked with the veterinarian a different veterinarian who was out of town, happened to be out of town the day this happened, and put me into physical therapy with a dog that pretty much had an atrophied leg and complete contractures and not using the leg. To make a long story short, they thought the leg would be taken off, and through physical therapy, my dog has her leg.
Yeah.
So, thank you for your time.
There's another member of the public.
Thank you. Dr. Ken Brucker again. And I'll be very brief because it is to this point. I think that physical therapists bring a huge amount of expertise to what we're trying to propose here, which is animal rehabilitation therapy. And to echo Carrie Ann's comment earlier, I feel, as a member of the public, a little bit of a disservice that we're trying to cram this in the last 45 minutes of this very important session. And I guess I think it should be allotted a little bit more time, and I would encourage that a second session where you kind of start with this topic could be useful for all of us. Thank you.
Any other comments from the public? Then I'd like to call for the vote, please. Oh, can I hear the motion again?
Sure. Physical therapist.
Oh, can I speak again?
We're going to call for a vote.
Okay.
Is it a matter of parliamentary procedure?
I don't know what that means. It's a comment on what other people were saying about that can be inaccurate.
I'm going to call for a vote. That means essentially that.
I'll allow you to say what you have to say.
Oh, I wanted to say that I know Dr. Klingborg was wanting to enforce inspections, and I think there's a lot of other ways to enforce inspections with being able to allow like a limited premises permit or other ways to allow for inspections so that that quality of care can be watched out for, and to make sure that people are having the kind of premises that are appropriate and safe. And it doesn't need to adhere to the current Practice Act the way it reads now, because we can insert different kinds of languages through a statutory fix in order to allow this to happen. So to say that that inspections can't be made, I think that's only in the framework of the regulatory language, but it can be changed through statute. And by saying just to allow the level of supervision by the veterinarian about the physical therapist, but having to be on the same premises as a veterinarian is really just a smokescreen, really, to keep the direct supervision that's been going forward for the past 10 years. So because now you're saying, yeah, I'll let the vet decide whether it'll be direct or indirect supervision, but I still want a veterinarian on site. So that's basically direct supervision. So, I think that all these things can be changed through statute, where we don't have to stay in the framework of the regulatory language. So to blow through this as fast as it's going, just to try to make the deadline right now, and to try to make this, fit into the current framework of regulatory language is, I have a huge problem with that.
Okay.
All right, we're going to call for the vote. Dr. Nunez?
No.
Lee Heller?
No.
Dr. Klingborg?
Aye.
Karen Atlas?
No.
Sandy Gregory?
I apologize. Can you restate the?
Sure. Physical therapists with advanced certification in animal physical therapy may provide animal physical therapy under the degree of supervision as determined by the veterinarian within a veterinary premises or range setting.
Yes.
Kristen Hagler? Yes. Dr. Holland?
Yes.
Dr. Schlachter? Yes. Dr. Sims?
No.
Dr. Troy? Yes. Dr. Van Dyke?
No.
Dr. Waldman? No. Dr. Chow?
Yes.
Shala Bar? Bill Gage?
No.
Carrie Ann Calais?
No.
Valerie Fenstermaker?
Yes.
Leandra Clark Harvey?
No.
I don't have 9, I have 8.
9 no's.
Oh, I have, 8 yeses. Okay.
The motion did not carry.
It's 9 to 8.
9 no, 8 yes. So we didn't finish our task. And I know that I said at the beginning of the meeting there will not be another meeting, and I truly did believe that when I said that. But I have been told by our representatives from the legislature that we will be able to have another meeting. The date, do we have any idea of the date at all?
To be determined.
May I say something? I want to thank everybody. Even if we're disagreeing, I really want to express my respect for your opinions, your passion, and your concerns, because I do believe that that's what you're bringing to this conversation. So thank you as a board member and as a person who cares about animals for what you're doing.
And I would reflect that. I want to thank everyone for the dedication and the respect that I think has been shown in this task force. And I might be even optimistic to bring a bottle of champagne at the next meeting.
I assume the meeting will be this year. I mean, are we trying to wrap this up? What is the, no?
Again, there may be some flexibility of when the report a recommendation can be made to the board.
Yeah, we'll change the date. It was January 1st. We actually have until April to do anything legislatively, so that would mean you could probably meet January, February. I think your board meets again.
We meet in January and then we meet again in April.
In April, yeah. So we could still, by April board meeting.
Just housekeeping logistical things. For the sake of not inundating the task force members with more documents that I don't know at this point are going to be any more helpful, I would ask that the information that we currently have be resourceful enough for us to continue on with the discussion. I can tell you it's a tremendous burden on staff in trying to disseminate all of this and use links because there's so much documentation. We can't print public copies. So unless there is some objection from the task force members, can we agree on the materials that are already available on the web links in terms of resource and background material for the sake of the discussion moving forward? Yes? Okay.
And Mr. Chairman, I presume that those items that we did not get to will just be deferred to the next meeting?
Yes.
And that comments or availability will be handled by the executive officer and her staff, correct?
We're not taking any additional information.
No, it's availability for the next meeting, timing.
Oh, I'm sorry, timing. Yeah. We'll make sure we schedule something. We have to look at the calendar. Just, can I ask, do you want to touch on if anyone has questions on the North Carolina issue? Because you sent out some information that I believe covered it, but, well, it's going to, I'm sorry. Next meeting?
Yeah.
Next
Okay.
meeting? Okay.
So without any business, we'll stand adjourned.
Then we,
Okay.
I'd like to move that we adjourn.
do I hear a second?
Second.
Then I don't have to call for a vote. We are adjourned.
We just kind of stand adjourned.
We are adjourned.